Good morning or good afternoon, depending on your time zone. Welcome and thanks for joining us for today's HIS Talk webinar, Top Predictions for Population Health Management in 2016 and Beyond. It's brought to you by Medecision. I'm Lori from HIS Talk and I'll be moderating. I have a couple of housekeeping items to make you aware of before we get started. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit questions to our presenters at any time. The presenters will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a follow-up email with a link to the recording as well as a PDF version of the PowerPoint presentation. We have two speakers today. Kicking things off is Tobias Samo, MD, who is the Chief Medical Information Officer at Medecision. Joining Toby will be Laura Kanov, who is Senior Vice President of Care Delivery Organization Solutions at Medecision. And with that, I'll turn it over to you, Toby.
Great. Thank you very much. Thank you, everybody, for joining. I've seen a list of those people who have registered, and it's an impressive list. So we're flattered and honored that you'd spend some time with us today to hear about this topic. A brief introduction of myself. I'm a physician. My specialty is infectious diseases. I've been involved with healthcare information technology for about 25 years now, and was the equivalent of the CMIO at Houston Methodist Hospital and then the CMO at Allscripts, and now I've been doing healthcare IT consulting. Let me let Laura introduce herself, and then we'll go ahead and get started.
Hey, great. Thanks, Toby. My name is Laura Kanov. I'm the Senior Vice President of Care Delivery Organization Solutions with Medecision now. Like Toby, I've been in the care delivery space for quite a long time. I was a respiratory therapist in a former life, as you can see. I did a lot of hospital operations before I moved into software implementations and then onto the vendor side of the world, where I spent a good deal of time at Eclipse's Allscripts in services and product marketing and product management and strategy. So I'm anxious to toss it back over to Toby and give you all some info on what we see population health management 2016 and beyond to be.
Great. Go ahead, next slide. So the objectives that I assume most of you have already seen when you signed up, but we'll go ahead and take a look at some of the market forces initially that are the driving providers into this brave new world of population health management, and then take a look on how these forces are affecting the various aspects of the healthcare delivery system. So the next slide. So population health management or value-based care, whatever you choose to call it, is coming. What we've been reading in the literature and what we hear from the market and industry leaders supports the proposition that traditional fee-for-service is waning and new models based on value will continue to increase. And I think at this point the only question is how quickly is that going to occur? There are some estimates, Frost and Sullivan is one of them, that in 5 years more than 70% of all lives will be covered by some form of value-based or risk-based contracts. In addition, CMS continues to push new payment models through the CMS Innovation Center, and they're looking at models that have the potential to reduce government healthcare expenditures as well as improving the quality of care. And they're effectively finding ways to test and extend the different risk of care cost and quality to the providers using a number of both carrot and stick initiatives. The Innovation Center has birthed a number of different projects around accountable care, value-based purchasing, bundled payments, primary care transformation, and beneficiary and specific initiatives like dual eligibles and programs for children. Other initiatives include now there's an entire new lexicon of abbreviations that all of us have to learn. So for instance, MACRA, which is the Medicare Access and Chip Reauthorization Act. Within that, the MIPS, or merit-based incentive payment systems, that basically adjust fee-for-service payment based on performances. Other APMs, alternative payment modules, have been proposed, and Medicare Advantage has really been gaining traction and shown success. There's been a lot of talk recently about the chronic care management fee, and this is clearly an expression of programs that are an extension of that wide variety of different type of value-based care payment and incentive models. We see that these market forces will lead to changes that will have a direct impact on various stakeholders involving delivery of health care through the population health management. So let's go ahead and look deeper into how physicians, care delivery, and patient experience, financial risk components, and technology will be affected by these new approaches of healthcare delivery. So if you see on the slide here, we have listed 12 different predictions of directions and impacts that will happen in 2016 and beyond. So let's go ahead and take a look, the next slide, that we've broken these up into 4 categories. The impact on physicians and other care deliverers, such as nurse practitioners, care delivery and the patient engagement, financial and risk models, and technology. So let's go ahead and take a look at the next one, which is the patient impact. So many physicians and other healthcare entities are holding back on accepting, much less embracing, these changes in the payment models. We hear comments like, oh, population health won't impact me or my organization. And with my background in the EMRs, sounds a lot to me like what we heard during the early days of EMR implementation. And look where we are with that now. As these changes become wider spread and successful, there will be a significant impact on physicians. As an example, physician groups will take a lead in delivering value-based care. It's been suggested that every Medicare and Medicaid patient will need to be managed by a well-organized primary care team, and this is a concept that has been expressed by NCQA. More and more provider groups are only taking Medicare Advantage and not accepting regular Medicare patients. PCMH have been shown to improve quality, cost, and experience of care according to the NCQA. Therefore, physicians will not only be responsible for the treatment of individual patients as they have had in the past, but will need to lead a team that will manage the needs of patients attributed to them. And this is going to take skills that have not traditionally been either identified or taught. However, there is a movement towards training future providers with team leadership skills. Some medical schools are now integrating leadership and team building into their curriculum. The MCATs, which my son is hoping to take in the spring, have added sections on critical analysis and reasoning skills, and another section on psychological, social, and biological foundations of behavior in order to try to identify those applicants that have the interpersonal skills that are needed beyond merely the scientific capabilities for future physicians. The next projection that we're making is that physicians will reject big data. Well, this may sound heretical. Big data is supposed to be the solution to all the ills of mankind. Now, don't get me wrong, there's much to be learned from big data, including broad trends and fascinating new areas of research. But the care provider, whether it's a physician, nurse practitioner, therapist, nurse, they need focused data that's presented rapidly at the point of care and within their workflow. So different entities and payment models need different types of data that is specific to their structure and incentive. Different value-based care entities will need information about outcomes that they can have a direct impact. So for them to be graded or reimbursed based on outcomes or measurements that they don't have an impact will not go over well. So different types of value-based care entities will need different data. However, the data does need to be comparable across models. So core data sets such as that has been proposed by the National Quality Strategy will need to be adopted across the continuum of value-based care organizations. So on the next slide, the way in which care is delivered and the effect on the patient experience is going to need to change significantly. So as an example, so new care delivery models will need to be created so that patients that have never stepped into a caregiver's facility gets the appropriate population and health care that they need. So one of the goals of population health is to keep the population healthy. Preventing illness and therefore patient encounters means that some of the members or patients may never step foot in the care provider's facility. This means a change in perspective for the providers. Despite not seeing the patient, the care delivery team will need to find innovative ways of educating these members and patients, using alternative means of communication, and engaging them, and use non-traditional venues of care such as community-based pharmacies, web-based interactions, and other modes to deliver quality and convenient care at reduced cost. Let's have the next slide. Another projection is that consumerism and patient engagement is going to play a much more significant role. So consumerism and patient engagement strategies will play a very important role in the ultimate success of value-based care. Patients and their families have an increasing incentive to identify the highest quality of care at the lowest price. Now, this is due to higher deductibles, higher copays, and other changes that place more and more of the cost on the consumer. In addition, the internet has made information much easier to obtain, and consumers expect transparency and comparison shopping in other purchases they make, and they're going to expect the same service in their healthcare purchases. Therefore, we project that there will be ever-increasing transparency of total cost of care and cost to the patient. We're beginning to see this type of information readily available to patients and consumer so they can make cost and quality-based informed decisions. The provider entity in the value-based care world needs to ensure that the patients that are attributed to them maintain allegiance to their care team so they can be managed without going to other providers that may cost more and not be incentivized to deliver the higher level of care that these models project. So the patients and their families need to receive the service and quality expertise that will ensure their allegiance to the primary care team. And lots of opportunities will exist to foster the relationship between the patient and their circle of support. A communication tool that allows communication between the patient and members of their support team, including physicians, care navigators, family members, home care services, is just an example of innovation that will enhance patient engagement. In addition, between now and 2017, the, quote, patient portal, unquote, as we know it, we project will be pretty much dead, or at least on life support, and will be replaced by more contemporary means of communication, such as phone apps associated with a personal health record. And that will enable for information to be delivered in real time directly to the patient and its support team through mobile technology. So next slide. Community-based plans of care will become ever increasingly important. So a very important means of managing and monitoring care is by the use of plans of care. These are used to identify specific problems that need to be addressed and monitor the goals that will lead to the improvement in the patient's status. As most patients have multiple problems and multiple caregivers, they can end up having many plans of care that are active at any given time. These multiple plans of care are created and stored in different systems such as inpatient, ambulatory systems, therapy centers, home care agencies, and these multiple and often overlapping or even conflicting plans of care need to be able to be viewed and managed from a single, easily accessible location without having to create point-to-point interfaces. This will enable all the care providers and patients to view care plans across the continuum of care and ensure appropriate coordination of care. In line with moves towards enhanced consumerism, these care plans will be readily available to the patient and their support group and be able to be accessed via their smartphones. So now I'm going to turn over to Laura, who will discuss some of the projected impact on the financial risk models and technology over the ensuing couple of years. Laura?
Hey, thanks, Toby. So just as Toby suggested early on in the presentation, the Innovation Center at CMS has spawned a number of projects around accountable care, value-based purchasing, bundled payments, primary care transformation, and beneficiary-specific initiatives. And what we've been reading in the literature supports what we hear from the market and industry leaders as well, and that's that they know the traditional fee-for-service is waning, and new models based on value will increase, and the only question is really how quickly is it all going to occur. So most providers that we talk to take on the risk of their employee populations, but beyond that, perhaps have only another 10 or 15% of the care they deliver at risk. One way that they have been transitioning into more risk is through bundled payments. It's a little more familiar and comfortable to sign up for care services that are managed in large part within the four walls of their institutions with some fairly well-defined start and stop parameters and a limited number of partners. So providers have a little bit more control and are therefore a little bit more comfortable with those types of scenarios. In 2013, there had been a number of demonstration cases that progressed in risk assumption from retrospective acute stay only through prospective full episodes, where the awardees take on the risk for all services related to the episode that they've signed up for. As of October 1st this year, there have been over 1,500, or there are over 1,500 participants from across the spectrum participating in this phase 2, from acute care, skilled nursing, physician group practices, home health organizations, inpatient rehab, and long-term care. Now, because Medicare and Medicaid are under extreme pressure, as you know, to reduce costs, they will continue to posit these types of payment reforms. In fact, in January 2016, they started a 5-year test of mandatory bundles in test regions for hips and knees. And just like the retrospective models used earlier, this is a fee-for-service that's reconciled against the target price. And if the episode payment is lower than the target price, and the hospital meets certain quality performance thresholds, then Medicare would pay the hospital the difference. If the episode payment is actually higher than the target, then the hospital would have to repay Medicare the difference. Now, the repayment responsibility would be waived the first year, and other policies in the proposal would limit financial risk a hospital would be responsible for during the test period, but it's things potentially to come. So I would expect an increase in mandatory participation in these types of models as CMS looks for more cost reduction opportunities from previous demonstrations in particular, like oncology, cardiovascular, and as it extends value-based purchasing downstream in the care community. The providers with more effective analytics, care coordination tools, and skills will be better positioned for success going forward. Physicians and provider organizations will get more comfortable with per capita costs as they move along a population health maturity curve. The growth in ACOs and the evolution of Medicare's alternative payment models, including next generation ACO models, offer a crash course in taking on risk using per member or per beneficiary per month payment languages. Right? So provider organizations must understand the cost at the per capita level to know what lines of business they can be profitable in. Care delivery organizations will undergo this transformation in thinking from managing patients to managing populations, and then back down to proactively managing specific patients or specific patient cohorts. As a result of rising above the individual patient or the individual care episode, they'll be better able to see the population stratifications at the cost per capita and how specific interventions are able to affect both cost per capita and quality, which are critical dimensions in the triple aim strategy, as you know. So during this transformation, physicians will come to appreciate tools and data that allow them to better understand their unique populations in order to better predict unwanted events and intervene in the most appropriate ways. You know, it's really interesting that we see this convergence in the marketplace and in our client base. We've been calling it the payvider space. And this is where plans are acquiring and aligning with ACOs and other delivery organizations, or providers or hospitals and health networks are standing up their own plans. And they're all moving to this middle space where they're taking on both the risk for cost and quality of the care delivery, even though they're coming from very different places in the spectrum. Practicing physicians have long known that certain intangibles impact the success or failure of patient treatment plans and recovery. Does the patient live alone? Do they have transportation? Do they have financial or social barriers to care? Often, the answers to those questions would determine when and how or if a patient would get discharged from an acute stay. A recent Harvard study has validated this intuition, recently published in JAMA. They reported that patient characteristics not included in Medicare's current risk adjustment methods explained much of the difference in readmission risk between patients admitted to hospitals with higher versus lower readmission rates. In fact, 22 of those 29 characteristics proved significantly predictive of readmissions after standard CMS adjustments, leading the researchers to claim that hospitals with high readmission rates may be penalized to a large extent based on the patients they serve, not necessarily the care that they deliver. A previous study at Henry Ford Health System, which was published in Health Affairs, had similar findings. Patients in high poverty neighborhoods were 24% more likely to be readmitted than others after they controlled for both demographic and clinical conditions. New predictive models will incorporate these non-medical characteristics to better inform action plans and goals. And CMS is likely to adjust payment in the future, not because they want to pay more for higher risk, but because they'll want to pay less for lower risk. So let's take a little closer look at technology. In order to effectively manage populations and patients between the visits, organizations will realize that their EHR investments just won't take them all the way there. They're great transactional and documentation systems, but they were not originally architected to work outside of the institutional walls the way that new value-based models are demanding. There will be denial and frustration, but in the complex, heterogeneous landscape of care that surrounds these high utilizers of care services like your multi-chronics, your dual eligibles, the technology landscape is just as complex. We find in our client base inventories of 20 or more EMRs that they need to connect, and there is not yet a strong incentive for the EHR vendors to create the kind of interoperability needed to achieve that free flow of information that supports that kind of comprehensive, safe, and real-time view of patients. In fact, you could argue that there are strong incentives to keep those barriers in place as a means to force expansion of the incumbent technology. However, not all community participants are controlled or governed by a single entity. In Medicaid expansion programs, for example, like those we see in New York, the New York District program specifically, We see competitive organizations coming together to coordinate for these Medicaid populations, and they can't force an expensive or time-consuming overhaul across the community, nor even across a network in many institutions. It's just not an option. Providers find they must leverage EMR-agnostic technologies to share data, health histories, community care plans, and communications with patient care circles, which include the patient and his or her family as requested. In other technology areas, SaaS-based solutions continue to grow and are expected to accelerate as well. Worldwide SaaS market is projected to be $50.8 billion by 2018, according to IDC. One reason is the favorable revenue model for vendors, but another big reason is that that's what the market is demanding. In hospital and provider markets, many IT capital budgets are still reeling from the effect of a costly EMR implementation and find it difficult to have to go back to the coffers and ask for funds to fill in the gaps of their EMR that the EMR has left them with. IT shops find SaaS-based solutions help move them from a CapEx to an OpEx scenario and allow them to employ specific point solutions before taking on wholesale population health management. Specifically, we see providers taking on point solutions that help them in both fee-for-service and fee-for-value that help them transition more predictively over time. So, for example, things like referral management and referral pattern analytics for network integrity help them keep patients in network for increased revenues, while at the same time help them manage patients with better visibility and control of patient care. As Toby suggested in the opening remarks, value-based models are not going away anytime soon. In fact, they're accelerating. We've talked about that in both government and commercial plans, as well as in that convergence of the provider and payer entities, our payvider segment, as we've called them. And what this has created is this interesting tapestry of organizational types. We find organizations at many different points along this curve as they mature in taking on risk with their patient population. From performance-based contracts and carrots and sticks that continue to penetrate fee-for-service contracts, all the way up to full population risk. At Medecision, we help providers and payers, for that matter, confidently take on the risk of cost and the quality in their populations with analytics and workflow and patient engagement solutions. Our view on the population health maturity curve starts with understanding the populations you serve, segmenting and stratifying, like what geographies, what conditions, what preferences, what problems, and then optimize how well you serve them. Starting first within your own four walls and then extending to outside of the walls of an institution into the community with evidence-based practices. Then as networks mature, they move from reactive patient care or care on demand to a proactive engagement to identify and address those gaps in care, promote clinical network integrity and all those things, to participate in coordination and data sharing in ways that they haven't done in the past. Ultimately, providers can take on more risk more confidently with better tools and techniques. They'll be able to predict and mitigate high-cost episodes while improving the patient's care experience. So we find that investing in the right data, analytics, the right tools, and the workflows and engagement at the right stage in each of those maturity levels helps manage the downside risk and helps our clients partake in the upside risk opportunities that now present themselves. So I'm going to end with this slide, just a little bit of a bullet point. One of our good clients who's in this payvider space is one of those clients who's been sharing some pretty positive outcomes with us, and this is just a scenario where they got this grant to reduce readmissions and had a 20% readmission in their 30-day, 20% reduction in their 30-day readmission. And with that, Lori, I think I will turn it over to you to see if there's any questions.
Okay, thank you, Laura. Now I'd like to open it up to the audience for questions. As a reminder, please use the questions section in the GoToWebinar console to submit your questions to Toby and Laura. The first question came just as Toby was finishing, so I think this is for you, Toby. Is it better to push useful care delivery information during a provider's normal workflow or make the information available for them to pull when it's not an interruption? What are the pros and cons of both options?
So the answer to that is yes, which means both. For physicians, and whenever I say physician, I'm including other, patient care providers, nurses, nurse practitioners, physician assistants, etc. So whenever every every person involved with the healthcare system has a primary IT system that they work with, either now or eventually will. For those care providers, it's the EMR. So we need to bring the information that they need into their day-to-day workflow. So there needs to be integration and communication with the EMR. Now remember that there are really two different aspects to population health management. One is the workflow that involves the evaluation of the entire population. So risk stratification is an example. Being able to do not a test, but understand which are the patients that you are actually responsible for. Those are all dealing with populations. But once those high-risk patients have been identified, or it could be patients identified that need hemoglobin A1Cs or that need their influenza vaccine, and you need to develop a campaign. Once you get past that population analytics and evaluation, which is very important, then you get down to specific patient interactions, and the physicians are the ones that are going to be involved mostly with that point of care information. So they need a list within their workflow, for instance, of what are the gaps in care for this individual patient. And so they will need that. Less frequently for the frontline givers of care, they're usually not going to need the overall outcomes, measurements, et cetera, for the community. That will probably be handled more by the chief quality officer, by the chief medical officer, whoever it is that's involved with that. So there should be the opportunity to access that information, but I think the key here is identifying the predominant workflow and make sure that you get the information that you need at the point of care within your workflow.
Okay, great, thank you. Jason would like to know, on your population health model, how much of the market is in each stage? So what is your impression of the overall maturity?
So Laura, do you want to speak to that?
Sure, I can take that. I wish I had data to share with you. What we found is that most of the providers are in very immature state. I know when we conduct focus groups and surveys with the Chime folks in particular, they're really in early stages. Almost everyone takes on the risk of their employee population, but beyond that, there's maybe 10 to 15%. Even some of the ACOs that we've talked to are still very early on and maybe are just doing some pay for performance carve-outs with a small segment of the population. Now that said, what we have seen is that the ACO market is increasing, and I believe I heard some numbers just recently that the number of lives covered under ACO is increasing about 15% this year. But there's still a lot of market to capture. So hopefully that, I'm going to say one more thing. I will say that we do have a significant number of clients in our purview that are taking on full risk in some areas. So we've got quite a kaleidoscope of clients in our with Medecision. I hope that answers your question.
Okay, the next one is from Chris, and Chris says, with the shift from episodic transactional-based care to longitudinal proactive relationship-based care, to what degree are you seeing or do you see the use of traditional CRM technologies in tracking and managing those relationships and interactions? And as an example, Salesforce and their Health Cloud offering.
Yeah, so I don't know specifically about that particular product, but I mean, you could say that all the population health products, not all of them, but many of them that are aiming towards that portion of the workflow is essentially a variation on the theme or a healthcare directed CRM model. It has its the healthcare industry is clearly unique, but it does not mean that it is completely different from other industries. So there are certainly much for us to learn from other industries, but really going ahead and looking at patients / members as your clients that you have to make happy on multiple levels will become increasingly important, and so a variety of tools that incorporate both the medical aspect as well as sort of more traditional client relationship management processes, I think just speaks how healthcare, which traditionally has been woefully behind in administrative technology. I'm not talking about CT scans and MRIs, et cetera, but the other aspect of healthcare information technology, we have been behind. This is another area where we have a significant amount of catching up to do.
Okay. Yeah, and can I add to that a little bit, Lori, too?
Sure.
I think that's a really interesting question because I think that to Toby's point, we have a lot to learn, and particularly when we know that one, if not the most important thing that contributes to patient health is how they engage in it. And the more we know about patients and what works for them, what their preferences are, and all of the elements around consumers that other industries have been really, really good at learning, I think that certainly is an area of interest in the future to be successful in population health management.
Okay, thanks, Laura and Toby. The next question is from Jason. How are provider organizations staffing up to address their population health needs? Is it their staff or your staff filling these roles?
Again, yes. It is both, and it depends, I think, on the maturity of the organization. There are some organizations that say, we have, especially a larger entity, that we have expertise we internally that we want to leverage in order to do that, in order to move forward. And then there is supplementation of or augmentation of the resources that are needed by other entities. But then, there are other entities that just say, we really don't know what to do here. And so, please come and partner with us on a much more basic level and supply that. So I think it depends very much on the entity and what level of engagement and what resources they have internally. Laura, do you have anything to add?
Yeah, I think that's true. I think one of the challenges is that there's a shortage of qualified resources in the market because it's so new. I was just looking for this there was a recent article in Hospital Health Network that looked at a lot of the population health, help wanted ads. So there's a number of areas that they continue to recruit for. But I think organizations are staffing up. We do some augmentation, but and they're reaching out for consulting help as well to get started. We've seen some new entities cropping up in the market to provide centralized care management services and offer them out, to ACOs or other entities. So I think that, anytime you see a market that's changing the way it is, you're going to see some entrepreneurial efforts, some new business models. I think we're going to see a handful of new things coming up to help staff and manage populations over the next few years.
The next question, where does an organization start on its journey to population health management? Does it start with technology, workflows, internal processes, and resources, or is it something else?
I can take that, Toby.
Okay.
So I would love to say that it were linear, like it would with governance and infrastructure, analytics, workflow, patient engagement, but it hardly ever is. What we see is that it needs to start with a good assessment of the organization and their strengths and what their goals are, because we see organizations and clients come in with different strengths and weaknesses. So they may be really good at patient engagement and not necessarily so good with their governance structure, or they may have good governance structure but not a good infrastructure. Or maybe they need to work on their change management culture before they can roll out tools. That said, you have to have a good sense of your population. So you need the analytics component to help you make good decisions and apply workflows to that. But again, we've got and I'll just say one other thing. So you have to do the assessment, and even within the same network, you'll have pockets of maturity and immaturity, within the same system. I know one of our clients talks about they have a program of their own where they contract lives to different physician practices in their geography, and they'll help them mature in understanding the populations as they go. So it's a little bit of a playbook, trying to understand where you are, what your strengths are, and then shoring up your gaps. So,
yeah, so I'll just add to that to say that, I love technology, but as we know, and those of you who went through EMR implementation, the technology aspect of it is, while extremely important, is only 20 to 30% of the effort. Most of the effort has to do with human capital, change management, process redesign, and that holds for getting into the population health management world as well. So a thorough evaluation of what is the status of your organization. Are they prepared? Are there aspects of, let's call it the psychosocial aspects of the organization that have to be dealt with before you can, move into some of the technological implementations that are required. I think a thorough, honest evaluation of who we are as an entity. Do we have the right environment to be able to go ahead and pull this off is a very important and probably at times a scary and challenging evaluation to go through.
Thanks, Toby. Last question, what are some examples of population health management solutions that providers are currently using, and how might that change in the future?
So I'll go ahead and take that. Well, I mean, you may, go ahead and break down, into different categories, but, one way to look at it is this an individual point of care solution that we're looking at, or is this a fully integrated suite? I mentioned earlier the concept of having workflows and processes that relate to the population as a whole, and then other processes and technology that impact the individual patient. So if I look at some of the technology that is needed to manage the population, to do your reporting and analytics, et cetera, that requires tools that have sophisticated analytics capabilities. And here we're seeing lots of different players coming in, some of them as standalone products, some of them as analytics capabilities that can be added on to other products, or analytics capabilities as part of a fully integrated suite. So I think that we will continue to see there's a lot of scientific evaluation that's going on, looking at analytics products, and there will continue to be some of what's called intellectual advances associated with that. So tools that do quality measures, outcomes measures, risk stratification is another extremely important, encounter grouping, and campaigns. So a campaign would be, gee, we see that only 60% of our population has gotten their influenza vaccine. We now need to have a campaign to go out and identify who they are and bring them in and get those up to the proper measurements to meet our requirements. So other tools that exist, and here we now start getting more into the individual patient care management. So I mentioned earlier about plans of care. I think where we're going to see a big change in that area is what I mentioned earlier, where we're going just from an individual kind of standalone plan of care to a community, or you may hear the term longitudinal plan of care. And where we are able to go ahead and bring the goals and interventions that are necessary that have been described in those multiple plans of care into a single, maybe not a single plan, but at least a single view. Care orchestration, diabetes management, care management, those yet to be some of the aspects of the previous person question about sort of CRM type of management. Those will continue to grow in necessity, because as you identify where you're not meeting your quality measures, you will need to identify the patients that are at highest risks, that need the specific attention, and that can get the attention that is needed by whoever's the appropriate caregiver. So other tools like referral management, utilization management, which we've typically looked at as a provider, as a payer tool, utilization management. Now as we get into the payvider market, we'll see use of utilization management internally within organizations as well. I think we're going to see a big change in the communication tools that exist. I mean, typically we've used a lot of phone calls, faxes, now some emails, but using a unified communications process that includes not only those technologies, but also telemedicine, instant messaging, secured instant messaging capabilities, apps that bring together the communication between various members of the support team. Those are all areas where I think we'll see a lot of growth. I hope that answers your question.
Great, thank you. As I said, that was our last question, so we'll conclude our webinar. I want to thank everyone for joining us today, and thank you, Toby and Laura, for an informative presentation. As a reminder to attendees, watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation. We look forward to seeing you at our next HIS Talk webinar, and I hope you all enjoy the rest of your day.
Thank you, everybody.
Thank you, everyone. Thanks, Lori.